Okay. Good morning, everyone. Thank you so much for your time this morning. My name is Brooke Oliveri. I am the manager of the Long Island Health Collaborative. For those of you who may not know, we are a group of approximately 300 plus county health departments, hospitals, community-based organizations, all working toward improving the health of Long Islanders. So as you can see here, today we are covering asthma, bronchitis, and COPD with Dr. Keith W. Harris. And this program is sponsored by AARP. We are so excited to have them on board with this series. And if she is on the call, I would like to introduce Doreen Day, an AARP volunteer, to say a few words. I'm not sure that she is on the call, so I think I will say a few words about AARP. So on behalf of AARP, welcome to today's Talk with a Doc webinar. We are committed to helping you stay healthy and stay connected, so we congratulate you for taking the time to learn more with AARP and the Long Island Health Collaborative. AARP is a nonprofit, nonpartisan membership organization for people age 50 and older. There are 38 million members nationally, approximately 2.5 million in New York State, and about 500,000 living on Long Island. AARP works to strengthen age-friendly communities and make for happier, healthier residents of all ages. And we advocate for what matters most to people 50 and over and their families, with a focus on health security, financial stability, and personal fulfillment. Learn more about other online classes, events, local discounts, volunteer opportunities, and more at aarp.org near you. aarp.org/near you, excuse me. Before we move on, I do just see a question in the chat. Is anyone else having trouble understanding? Is anybody else having an echo problem? If you are, please speak up. Okay. So Barbara, I apologize that you're having that issue. I do see that you're in the meeting twice. So if you might be on a phone and on a computer, or something like that. I'm not sure why you're in here twice. I do apologize for the difficulty though. I know, I see you're shrugging. I'm sorry. I'm not sure what the problem is. I do have a few questions for everyone to answer before we get started here. I'll go ahead and launch those right now. Some pre-event poll questions. These help us to inform future programming and to evaluate the success of this program. So we would really appreciate your feedback. I see a lot of answers coming in. Thank you, everyone, for giving us your feedback. We really do appreciate it. Okay, I see 14 out of 20 have participated. I'm just going to give it another 30 seconds here. So please get in those last minute answers.
Hi, everyone. while you're submitting your poll, my name is Erica Karp. I'm the Community Relations Representative for Stony Brook University Hospital. And I just wanted to jump in. We have a ton of different resources for you at Stony Brook. For those of you that live locally close to the university in Suffolk County, you may be interested in our Mall Walkers program, which meets on select Wednesdays throughout the year. And it's a great way to interact with other people. It's a great social event. In addition, we have our Stony Brook medicine experts come for lectures on different topics throughout the year. So think if it's a different month, it's typically themed. So if it's cancer prevention or something like that, it's really wonderful. And then you also have an opportunity to take a walk around Smith Haven Mall. So it's a great way to get some exercise, which is always nice, right, Brooke? So it's temperature controlled, flat surface, and you can go at your own pace. So, and I'll also share in the chat just a link to our event calendar at the university. And you'll see that there's a ton of different programming options at the university and university hospital, in addition to opportunities through Stony Brook Medicine for screening and screenings, health screenings and whatnot. So I'll share that in the chat, and please let me know if you have any questions. I'm happy to answer them in the chat as well.
Thank you so much, Erica. And yeah, we're so grateful to Stony Brook for being on board with this program. And thank you so much for being here today. So I did close out those poll questions. Thank you to all of you who gave us your feedback. We really do appreciate it so much. And thank you to Erica for putting that calendar in the chat. Please check that out for those events she was discussing. And I will go through Dr. Harris's bio while we're waiting for him. So today we have Keith W. Harris, MD. He is a board certified physician in internal medicine in the subspecialties of critical care and pulmonary disease. As you can see here, he studied at the Philadelphia College of Osteopathic Medicine in Philadelphia, followed by an internship at Good Samaritan Hospital. He went on to complete his residency in general medicine and his fellowship in pulmonary and critical care at Stony Brook University Hospital. Upon completing his fellowship, he began working at John T. Mather Hospital, where he helped create the intensivist department. And as you can see, it is a pretty impressive bio here. We are very excited to have him speak, and it'll be worth the wait, I promise. So we'll just give it another minute or two here, and hopefully Dr.
Hi there, I'm sorry.
Oh, hello, good morning.
Thank you for the introduction. Totally unjustified on my end. I didn't earn any of these things. They're all made up. But thank you for having me. And I apologize, I was just running late with the last patient.
Totally understandable. We know patients come first, and we appreciate that and your participation this morning. So thank you for joining us. And without further ado, Dr. Keith Harris.
So thank you again for having me. We're going to speak briefly about the three things you see up on the screen. Truthfully, they kind of all lump together. And so we're going to kind of break them apart and put them all back together. So things that are called obstructive airway disease simply means that your airflow out of your lung is not emptying the way it should. I make lots of analogies for patients in the office. If you think about a drain in your house or a hose in your yard, you expect a certain amount of water to come out of the end of each one of these things. So if you were to park a car partially on a hose, or if you were to put something in your drain that keeps the water from going out, the full amount of water would not move out of the hose or the drain. And that's what obstructive airways are. As you're blowing out, as you're trying to breathe out, you actually can't get all the air out of your lung that you would normally be able to get out if it emptied properly. And so that's actually the physiology for asthma. It's the physiology for chronic obstructive pulmonary disease, or COPD. And to some extent, it's the physiology for bronchitis. And so when you have these conditions, depending on whether they're acute, like a bronchitis where you're sick and you have an upper respiratory infection, or chronic symptoms in COPD or asthma, the treatments are somewhat the same and somewhat different. So separating them out, asthma is a fully reversible airflow limitation. So if everything I just explained a second ago kind of makes sense, and along the way, if anybody has a question, please just yell out. Don't wait for the end of this. If something doesn't make sense, it's better to re-explain it as we're talking about it. So if everything I said before made sense in terms of airflow, asthma, when you give people medicine, the airflow becomes normal. So you think about that car that's partially parked on the hose, and that's your asthmatic lung that can't get all the water out of the end of it. If you take the car off the hose, all of a sudden all the water comes out of the end of it, and you're okay. And that's asthma. So if we treat you, we put you on medication, and we do our job and your lung behaves, your lung will open up and the air will move out of your lung completely the way it's supposed to be. And so those symptoms can range from lots of different things. They can go from something as simple as, well, I've noticed some wheezing and some shortness of breath, and that happens to occur certain times of the year when things I know I'm allergic to are out and bothering me, or if I go to my neighbor's house who has a cat, all of a sudden I can't breathe and I notice I'm wheezing and I'm short of breath. Those would be classic symptoms for asthmatics. But there's actually less classic symptoms that we've struggled with in the office. There's a group of people that are referred to as cough variant asthma. So their symptoms are simply just a cough. They come in and they tell you about how everyone looks at them and nowadays wants to throw them off the building because of COVID. But they're coughing and they can't stop coughing, and there isn't seemingly one specific reason why. And they may actually not wheeze and they may not be terribly short of breath, but yet they're coughing all day and they don't know why. Their spouse wants to kill them, the kids don't want to talk to them, the neighbors won't come near them. And they're actually treated also the same way. So all of those types of symptoms can be an asthmatic. Sometimes it's easy. The person comes in and tells you they have a history of asthma as a child and they quote unquote outgrew it. And then all of a sudden they had new symptoms recently after being sick. And the tests that we do to make a diagnosis is something called a spirometry or a pulmonary function test. But truthfully, the most important diagnostic tool is just talking to the patient. While all of those tests that I just said are useful and they certainly help to make a firm diagnosis based on what we consider criteria, either by the GINA guidelines or the other guidelines that are out there for managing asthma, talking to the person is really the most important part. So if you're speaking with a person, usually 90% of the diagnosis comes out in speaking with them. And so these people come in and they tell you the stories that I was just saying. One of my more common stories is someone who's maybe in their 50s or their 60s, and they come in and they say, well, my mom always told me I just wasn't a good runner. And the problem was that when they were kids, they couldn't keep up with everybody because they had asthma. And back in that generation, we didn't have, even in my generation, we didn't have very good tools to treat asthma, let alone make a diagnosis. And so their symptom really was, I can't run, and it was because they couldn't breathe. And so you can then do a spirometry or a PFT, and then it would show airflow limitation, like we talked about in the beginning, whereas the person's blowing out in the breathing test, that all the air doesn't come out. And then we give them a medicine, and the treatments can range from what we call single medication inhalers, something like an albuterol, which is a rapid inhaler. For those of us who are old enough to remember Primatene Mist, that was an equivalent of albuterol. It was a medicine that had been taken off the market for a period of time and is now back on. But they're short-acting, rapid medications. And what's quite interesting, a few years back, I had the opportunity to give a lecture to a nurse practitioner regional meeting in Texas. So there was about 500 and something people there. And I went back and I pulled back the history of asthma. And what's interesting is a lot of the terms in the clinical findings we talk about now have been described for hundreds of years. Some of them post-mortem, some of them actually clinically when their patients were being examined. And a lot of the medicines actually stem from therapies from, again, over 100 years ago. And so most of the medicines on the market, like Primatene Mist and albuterol, are rapid-acting onset medicines, and they're stimulants, if you will. They help to open up the airway through what we call the sympathomimetic system. The other treatments on the market are inhalers that have longer-acting medicines. Some are inhaled steroids. The analogy I give people are they're not a kind of steroid that you swallow that most people are scared of. Either they hear about side effects or they're worried about growing hair or losing hair with steroids. But they're kind of like a steroid you put on a poison ivy, that you breathe this inhaler in, that topical medicine in the steroid goes in and reduces the inflammation, and the airflow in your lung improves to normal. There are other medicines as well. They're long-acting medicines that are inhalers as well. And some inhalers now actually have 3 medicines just in one. So some of the newer medicines on the market now, you can take 1 or 2 puffs of an inhaler and get 3 medicines at a time. And so that's kind of the summary of asthma simply. When you come in with a simple history or a nice, history of having had it as a child, we do a diagnostic test that confirms it. We put you on treatment. We should see that your airflow and your symptoms normalize. And so that's fully reversible airflow obstruction or asthma. Bronchitis is a much bigger topic that we're not going to be able to explain completely today, but itis at the end of the word bronchitis just stands for inflammation. Bronch, B-R-O-N-C-H, just is your airway. And so what it's basically just saying, bronchitis, is that you have airway inflammation. That inflammation could occur from lots of reasons. Most people are familiar with bronchitis due to some sort of an infection, albeit a bacteria, a virus, whatever it may be. The inflammation, the itis in your airway has occurred because of whatever that infection was. But there are other causes. There are truly inflammatory processes, rheumatologic diseases, other pulmonary diseases where you actually just have inflammation and it's not due to an infection. So those symptoms are actually quite similar to asthma. People typically come in coughing, they may be short of breath, they usually are wheezing. If it's an infectious cause, they may have come in with a fever, they may have mucus or phlegm. Or if they actually have just been exposed to something that triggered this, we've had patients who worked in certain environments. One gentleman who sticks out was a guy who worked at Lowe's, and in the back there were pigeons and birds, and there's an inflammatory process in your lung called pneumonitis that can occur. And this gentleman would feel well when he wasn't at work, and then he would feel bad when he got back to work, and it was all because the things that he was breathing in from the birds were causing airway inflammation. And so his symptoms were coughing and shortness of breath and the things that we talked about. And that the diagnosis of bronchitis is a little trickier because there are infectious ones, in which case you might want to treat with an antibiotic, or if it's a certain type of virus, there are a few treatments for viruses. But if it's an inflammatory process, the best treatment is typically to remove yourself from the inducing agent. So in this guy's case, when he left work, he felt better. But sometimes there aren't things that you can remove yourself from, or sometimes there are things that no matter being removed, you still have problems with inflammation, and you need treatment. And those typically center around steroids. So the diagnosis in that case might be with a CAT scan or an X-ray, or possibly a sputum culture, depending on what the patient's story is. But it all still comes back to talking to the person. So most of your diagnosis is going to come from simply talking to the person. If it's a patient who comes in and says, well, my grandkids were over and they snotted all over me and now I feel sick, well, you probably got an infectious cause. Now you got to just figure out what you're going to treat them with. Versus this gentleman who you had to literally listen to his whole story and pick apart when he went on vacation and when he took a week off from work, how he felt much better. And then when he went back, he would have new symptoms. That leads us into COPD, which is probably something that most people have heard about before. Unlike asthma, which is fully reversible, COPD is chronically obstructed. So those patients, no matter what you put them on, may always have a little bit of airflow or a lot of airflow obstruction. So back to the analogy of the car on the hose, their car would never completely come off the hose, and there would always be a little bit of blockage on the hose. It doesn't necessarily mean those patients will always be symptomatic. It just simply means that if you were to do a diagnostic test like a spirometry or a PFT, which are breathing tests, those people will not have fully reversed airflow the way an asthmatic would. So you can kind of take the top bullet of the asthma and the bottom bullet of COPD and understand that they're very, very similar. And the thing that separates the two is that the asthmatic should go back to completely normal airflow in the diagnostic test, whereas the COPD patient won't. So their symptoms are similar to the first two people. They may present with coughing, they may have phlegm, they may have shortness of breath, they typically do. Sometimes they wheeze, not always. And when you're speaking to them, you usually can get from their history either a smoking history or an occupational exposure history. There are many patients who have worked in jobs where even though they haven't smoked, they've been chronically exposed to things that have led to injury to their lungs similar to when they were smoking. In the world, the second leading cause of COPD is actually occupational for people in other countries. Many cook over open flames and in confined areas. They heat their homes differently. All of those particulate matter that you're breathing in, even though it's not in the form of a cigarette, can cause the same problems. So the symptoms are very much the same. And sadly, with COPD, even though we are doing a better job at taking care of it, we still have not as good outcomes as we would like. If you look at the other problems that plague us in medicine, heart attacks and strokes and cancers, we've been very successful in making improvements on how to treat and cure some of these diseases. COPD, it's a little bit harder. A lot of the medicines that are out there help to improve a person's symptoms, but they don't, quote unquote, cure it. That being said, many, many people live with it and are completely fine. So in speaking to a patient, you have to be a little delicate because they hear about things on TV or they read about things and they are assuming this horrible future for themselves. And in truth, what you have to say to them is it's much like hypertension or high cholesterol or diabetes. It's a condition that right now we can't necessarily cure, but we can make you feel better and have you have fewer symptoms. And with all of that, you will live with the disease, no different than most of the other diseases we live with. So the diagnostic tests are very similar to the asthmatic. There's spirometries and PFTs, and to some extent similar to the bronchitis patients. We may get CAT scans. In this case, there's actually genetic testing that sometimes we do because about a 10%, give or take, of COPD is genetic, something called alpha-1 antitrypsin deficiency. And so that's actually a simple test that your doc or yourself can have done. It's just a swab of your mouth to look for the enzyme in your lung that should be protecting you from developing emphysema. And while 10% of people with COPD have that, 9 out of 10 people don't. But we are supposed to be screening people for that because it's a treatable process. So the diagnostic tests are similar, and the treatment actually is quite similar to asthma. So most of the inhalers on the market for asthma can be used for COPD and vice versa. There are a few that are more exclusive just for COPD or just for asthma and don't overlap, but many of the ones out there can be used in both. And so those patients would get put on an inhaler or a pill. There are a couple of pills on the market that we use for COPD. Or in the case of the genetic issue, there's an infusion that we give people. And what happens is the medicines work to reduce the inflammation, just like the inflammation in bronchitis and just like the inflammation in asthma. The inflammation in COPD is similar. And what we do, or what the objective is with the treatment, is to reduce that inflammation, let the lungs empty out better. It's the same old theme. I feel like a broken record. And as the lung empties out better, people typically feel better. Those patients often have a little bit more presentation of chronic cough, and those medicines with an inhaler sometimes help, and other times we have to give them different medicines to control the cough. So with that being said, what we've talked about with these three conditions would really fall under the category of obstructive lung diseases. And there are actually quite a few more. But for the purposes of what we're talking about today, this kind of hits what most people have heard or familiar with, or someone in their family has. And they really have, although three totally different names and to some extent totally different timelines of symptoms, they actually present with very similar initial symptoms, very similar diagnostic tests, and to some extent similar treatments. So hopefully that was helpful. Hopefully that explains some of these three topics, but I'm more than happy to answer as many questions as anybody has.
Thank you so much, Dr. Harris. And before we get to our questions, we just have, so the Long Island Health Collaborative is a big proponent of walking to reduce your chances of having a chronic disease. So just some tips and laws for walking safely. Always use the sidewalk. If there's no sidewalk, always walk facing traffic. That is actually a law. See and be seen, wear brightly colored clothing, carry a flashlight when you're walking at night, make eye contact with drivers when possible. Cross streets at corners or in crosswalks. Don't text on your cell phone while walking. It can be just as bad as doing that while you're driving. And for more information, you can visit walksafeli.org for other tips and laws. So once again, thank you, Dr. Harris. And now we'll open up the floor for questions. I do see some in the chat already here. So
just to follow up on that, I would like to say that it's a great segue for what I end up talking to many of my patients about. The old adage of a rolling stone gathers no moss. it couldn't be any truer for any other disease than COPD and to some extent asthma. Those patients need to be mobile. The more you are active, the more portions of your lung that aren't being used when you're at rest get used. There's plenty of studies that have looked at this, particularly after hospitalizations. In the first 30 days after being in the hospital for a COPD exacerbation, you have a much higher risk of going back into the hospital for something else. And there's very good data from about 2010 from a gentleman by the name of Dr. Hurst, where we looked at patients, or he looked at patients with COPD, and the likelihood of going forward and having more and more problems was completely and totally hinged to already having had a problem, and that by being mobile, using medicines, and staying out of the hospital, we helped avoid those things. So it's a perfect slide.
Great, thank you for that. So I guess I'll just start with the questions in the chat. Someone says EpiPens are used for asthma. Are they used for the other two emergencies, bronchitis and COPD?
So great question. They're used in asthma more so because many asthmatics, and nowadays we're finding more and more of them, are on some level intertwined with allergies, in which case there's a chance for what we call an anaphylactic response to an abrupt exposure to that allergen. Some people are on medicines that we didn't get into in asthma called biologic therapies, where they take a shot to kind of like an allergy shot, if you will, but a little different and not, a little bit more complicated for a conversation than we have time for today, where that you could, in theory, have an allergic reaction to the shot that's supposed to be treating you for that, and you need an EpiPen for that. Generally speaking, no, we don't use EpiPens in COPD or bronchitis because they're a little bit of a different physiology, and we have fewer of those patients that are struggling with allergies. If a person had specifically allergies and had a history of an anaphylactic reaction, then yes, but as a rule, generally no.
Thank you so much. I see Jane has her hand raised if you'd like to ask your question.
Yes, hi, good morning. I'm wondering if you could tell me when you recommend pulmonary rehab for someone with COPD. Is it based on their stage, or is it something that you would generally recommend?
Great question. The answer is yes, not to be silly. Pulmonary rehab has been studied over and over and over again in COPD, and those patients overwhelmingly do better. They do better in the sense that they are less likely to end up in the hospital. They feel better. Something we refer to as their quality of life is measured as better. And so we are big, at least I am, a big proponent of pulmonary rehab. I would not send, or I would not deny anyone access to pulmonary rehab who asked for it at any stage of their disease. So even if they were mild and not had an exacerbation recently and weren't using their rescue inhalers, I still would say, look, if you want to go, great, I would love it. Most people who are that functional are willing to do their exercise on their own. They're not necessarily looking for a guided tour of therapy, which is really what rehab is. They might go to Planet Fitness on their own, or they might walk in their community or do exercises in their own home. But exercising in general for all stages of COPD and asthma, and truthfully for pretty much any disease, is a good thing. Who do I specifically target? If you look at the guidelines, the people we're trying to target are those who are having more struggles. But the goal is to find them earlier rather than later. Not having the person end up in the hospital 2 or 3 times before you bring up pulmonary rehab, or not have them, have 2 or 3 exacerbations and end up on prednisone before you bring up rehab is the goal. So I would send anybody, particularly anyone who asks, but who would I target are the people who can't seem to develop their own exercise program for all the reasons we kind of went over, and who would benefit from avoiding exacerbations.
Thank you so much.
I also see Moira Lee has her hand raised.
Hi, thank you. Thank you, Dr. Harris. I have a few quick questions. So you mentioned about if there's hereditary factors, or is there hereditary testing with asthma you mentioned? And next quick question is, is it a wives' tale that, when they say like with allergies and asthma, if kids get it very young, a lot of times they outgrow it after puberty kind of thing. And with COPD, my mother, who never smoked, my family smoked decades earlier, but she died of COPD and she wasn't around smoke for decades thereafter, but never smoked, never nothing. I've been asthmatic since I was 18 and I'm 57 now. So, but it's quasi under control. Thank you.
So I'll try and answer those in sequence. If I mess it up, please just correct me. So the first question I think was genetic testing. In asthma, there's not so much genetic testing, but there should be allergy testing in asthmatics you can't control. So if you have a simple run-of-the-mill asthmatic who's doing well, doesn't regularly need their rescue inhaler, is controlled on a maintenance medicine, and feels good, then even though they may have allergies, we focus less on them. If you are an asthmatic, about 10 to 15% of asthmatics are what we refer to as difficult to maintain or difficult to control. Language nowadays is carefully, you have to worry you make somebody upset. But really what we're trying to reference is there's about 10 to 15% of asthmatics who are needlessly having exacerbations, and they often center around something called an eosinophil or an IgE, which is an allergen. Those people, there are medicines on the market that specifically treat those two things. There are genetic conditions that if you're treating an asthmatic, you may want to think of because maybe their genetic problem is really their issue and their asthma is not. What I mean by that is sometimes asthma becomes the diagnosis and it's really being missed and it's something else. But as a rule, in general, we aren't rushing to do too many genetic testing in asthmatics. You would focus more on the control symptoms, the triggers that might be going on, the use of the medications, and then the allergy stuff. As far as COPDers go, there is a genetic disease called alpha-1 antitrypsin deficiency, which is specifically a COPD disease. It was determined or stumbled upon 50 plus years ago by a doc and his resident, and there's been a treatment for some time and there's been screening for it for some time, but lots of docs are not familiar with it. There are other genetic conditions like cystic fibrosis and ciliary diseases, and these are all things that wouldn't be exclusive to COPD or asthma, but if you had a patient who you couldn't seem to control, as a pulmonologist, you may be thinking, geez, am I missing this diagnosis? This person's been labeled with asthma, but yet they're just not controlled, and I have to think about these other things. The second question I think you said was about your mom. Is that right? You mentioned that your mom had been diagnosed with COPD, passed from COPD, but never had smoked and never had had a reason to have had it. That would be someone or someone's family where you would look for alpha deficiency, because those people are more likely. What alpha deficiency is an enzyme in your lung that protects you from developing emphysema. So what happens is when you're missing that enzyme, you are very likely to develop emphysema from limited exposures, unlike the rest of the population where only about a third of smoking patients end up with emphysema. So that's a simple buccal swab. That's a fancy way of saying the inside of your mouth. It's a free test. It can be done. You can order it yourself. But you can also just have your docs do it. We obviously do quite a few of them in the office, but anyone can get that test and do it to see if they are missing that enzyme. And that's a whole talk in and of itself. And then I think the third question was about yourself, right? You said you are an asthmatic, you've been reasonably well controlled. From my perspective with your mom's history, even though you're quote unquote an asthmatic, I would definitely think about swabbing you for alpha, although again, statistically speaking, it's exceedingly unlikely that you have alpha deficiency and have made it this far without being diagnosed. If you actually look at the original registry of about 400 patients, many of them were not young. They were actually normal, my age and older, who had been not diagnosed because their assumption was they had already had the disease they had, whether it's asthma, COPD, and geez, how did they make it to 47 years old without having a diagnosis of alpha deficiency? And that's just simply wrong. So given your family history, although statistically speaking, it's unlikely that's what you have, you should be screened. There's no risk to it. There's no danger. It's a once and done test. It should certainly be something you would want to do.
Did you say that was called the buccal test?
So it's called an alpha-1 antitrypsin deficiency test, but it's actually a buccal swab. So the word buccal in medicine is for the inside of your mouth. It's spelled a little different than the one that's on your belt, but it's referred to as a buccal swab. So what happens is they swab the inside of your mouth. We're all familiar with swabs now after 3 years of COVID, but they swab the inside of your mouth for about 10 seconds, and all it's really looking for is that particular gene. So again, people come in and they're thinking of 23andMe and all of the other genetic tests that are out there. That's not what this test does. All it simply does is screen for that particular enzyme. With your history, I would suggest is worth you or your doc pursuing.
And it's a pulmonologist that normally does it, not a primary care doctor?
Primaries do them. I would like to say that all primaries are familiar, but they may not be. They also, there has been for many years this thought process, like I was alluding to before, that if you've made it to a certain age, it just simply can't be the diagnosis because there's no way you would make it that long if you had this problem, and that's just not true. So we've been working really hard. The Alpha Foundation, the companies that I deal with for alpha deficiency, the Alpha Foundation is an international company that has no particular allegiance to any pharma company. It was founded by a man who actually had alpha deficiency and for years was being told that he just had bad asthma or uncontrolled COPD. And when he tracked his family history back, it turned out that several people in his family had passed away at young ages, similar to what you described with your mom, for reasons that didn't make any sense. And when he screened himself, it turned out he was a purely deficient patient, and his family, his brothers and sisters were. And so he was a very, he had a lot of wherewithal, I guess would be the right answer for this. And he was able to found an international society after several years that focuses on this and works with the pharma companies that give the replacement therapies and all of the pulmonary societies out there in terms of making sure that people get screened.
Thank you.
So your doc, I would just go in and say Alpha 1 screen. And then if they're not familiar, you can tell them to call my office. I'll give them my cell phone if you want. We want people to know how to get this test. It's free, it's once, and it's simple. There's just simply no reason not to do it.
Thank you.
That's great to know. And I think we have time for one last question. I see Michael has his hand raised if you'd like to unmute and ask your question.
Yes, hi, thank you for taking my question. My name is Michael Murray. Can you hear me okay?
Yes, we can hear you great.
Sure.
Perfect. I have COPD and emphysema. I had a recent CT scan that showed a bunch of nodules in my lungs. I think the nodules might potentially be congealed mucus because I've had a lot of nasal drip and runny nose and whatnot this spring and summer. I'm beginning to wonder if I picked up a new allergy. Anyway, long story short, I was wondering if anything like steam or a decongestion or something like that might help me dissolve these nodules if they are mucus. And well,
So it's a good question, Mr. Murray, and CAT scans are a big part of my life. I see quite a few CAT scans every day. I talk to people about CAT scans literally almost in my sleep, it feels. And nodules are incredibly common. About 50% of the general population have them. So if you were to research pulmonary nodule, and I would certainly not suggest doing this, but if you did, you would find that about half the world have them. So if you take that number in New York, it would be roughly 9.5 million people have pulmonary nodules. So it's a pretty common problem. And nodules come in two different flavors. There's one called a solid nodule, and there's another one called a semi-solid nodule or a ground glass opacity. And one isn't necessarily better than the other, and there's all kinds of reasons to have them, and how to manage them and how to handle them is a whole nother talk. But your question is a good one. Are your nodules the ones that are going to go away? Because many people have those nodules. Or are your nodules ones that aren't going to go away? If your mucus was stuck down in there and it was creating your nodule, either one of those situations could happen. You could potentially cough it up and then that nodule may go away, and we see that commonly on reports. Or it may very well be stuck down in there and it's in such a small, tiny little airway that there ain't a darn thing you can do to try and get it out. So, common sense with this goes a long way, and nowadays that seems to have been forgotten. So using inhalers or whatever medicines your doc has you on is a good thing. Exercising, like we kind of spoke about earlier, helps to stretch out and open those small airways that when we're at rest and we're not doing much don't get used an awful lot. And then, yeah, sure, any humidity and mucolytics and things like that, managed by your doc and you make total sense. And it may lead to them going away and it may not. The truth is with nodules, what we do with them is we follow them. If one of them were to start to grow, it could be a big clump of mucus down in your airway, and then sometimes we have to get fancy as to how to get that mucus out of you, or it could be something more concerning. But the way to manage all of them is basically just to make sure they get followed up.
One quick follow-up. Could these nodules contribute to my shortness of breath? Could they exacerbate my symptoms?
So good question. It's a tough one to answer. What I would say to you is that in theory, yes. Do most nodules cause people shortness of breath? The answer would be no. But truthfully, if there's enough mucus down in your airway and you have enough nodules that are plugging up your airways, then yes, in theory it could. So in general, most nodules don't, but in your particular question with what you're thinking your nodules may be, if there are enough of them, then yeah, it could be.
Yeah, my thought was just already being compromised. Even the loss of a little lung function is noticeable, perhaps. Doctor, thank you.
So you nailed it. That's absolutely correct. So the issue is your level of function might not be the same as the next person's, and that loss for you might be very different than how it impacts the other person. You're absolutely right.
Thank you, sir.
Yes, sir.
Thank you so much, everyone, for your questions. Thank you, Dr. Harris, for all of your great answers. And we do have some final parting questions for our attendees here. If you would, please give us your feedback. We would so appreciate it. And while you are answering those, I will just mention, we have 2 upcoming walks to culminate this event series. One is at Belmont Lake State Park on Saturday, August 6th, and one is at Jones Beach on Saturday, August 13th. You can find all of the information about these walks at lihealthcollab.org. And we would really love to see you there if you would like to participate. So
thank you very much, everybody. I hope I was helpful. If I can be of any help to anybody or their docs, please feel free just to let me know.
this was a wonderful program. Thank you so much for your time today.
Yes, thank you very much. Have a great day, guys.
Thank you. Bye-bye.
Bye-bye. I see some other people are answering the poll. Thank you so much. I'll give it another 30 seconds here and then everyone can get on with their day. All right. Thank you all so much. Once again, thank you for your time and have a wonderful day.